Namaskaram, my name is Asif, working as speech therapist, Pinnacle Blooms Network, Nagar facility. So I am here to talk about implantable hearing aids. So let me start about how we communicate. So first we hear something, then we will comprehend that, then we will analyze that, then analyze the response, and then we will give a verbal response. That's how we communicate. So what's with the people who can't hear? It's the first part of communication. So for that, let us assess how we hear. So we know we hear with our ear. So what we see from outside is the outer ear. That contains a pinna. That's what we see outside, and there is a tube which conducts our like external sounds from environment to inside the ear. And there is a thin membrane, which is a tympanic membrane, which conducts the sound into the middle ear. So in middle ear there are three bones, which is malleus, incus, and stapes, which conducts the sound into inner ear. The inner ear is what converts the sounds into neural signals, which then conducts into the brain. So this is what happens in the ear. So what happens if this mechanism didn't work perfectly? So let's start with the outer ear. What's with the kids? There are kids born without ear. We call it anosmia. And there are kids without that tube which conducts sound into the ear. Or what happens if there is that recurrent like infections, fluid filling, and all. So it all happens. So what with these kids? Or what happens if there are many conditions in which this mechanism stops? So let's start step by step. So if there is a less amount of issue, so you have seen there are things like hearing aids which were outside our ear, which will just amplify sound, like what we do with microphone and speaker. It just amplifies a sound and it will send into the ear. For that too we need a proper ear. What if the kid have no ear? Then for the first part we will use a mid-ear implant. Mid-ear implant in which we directly conduct the sound into the mid ear. So the kids with the outer ear or this opening or something like recurrent infection is happening, for that kids will give a mid-ear implant. So in mid-ear implant what happens is there will be an external processor will be there which will collect the outer sounds and process it into an electric sound, and it will conduct, and there will be an inner implant, and there is an implant directly placed onto that bones which will help in directly conducting sound into the middle ear, bypassing the outer ear. So if the kid have some serious issues with the outer ear or the absence of outer ear, we can directly conduct the sound into the middle ear. Then the next thing is, so by this thing, if the kid have some external ear issues or something, we can directly conduct the sound through that. For that a surgery need to be done. So we will place an internal processes through surgery directly into the middle ear, and we will conduct the sound collected from the outside, which is processed by the external processor into the internal processor. Then this internal processor will conduct this, assess the sound and do some corrections, and it will send it into that vibrator placed on that bones, and it will so it is directly conducting into the middle ear. So there is an issue, like middle ear is prone to many infections, like middle ear infections. Even if we go, many of us have experience, if we go in an aeroplane or air flight, or we are going from a higher place to lower place, we have that issue of like ear fullness or a closed ear. For that, then what happens is there is a connection, or there is an airway connection or ventilation for the middle ear, so that it will work. It's an air filled cavity, so it can work easily without infection, that with proper ventilation. So sometimes this tube get closed. That's what it happens when we are taking airlines, or we are changing the altitude suddenly like that. So this area is prone to many infections, that middle ear, where what we use the sound to like directly transmitted into the middle ear in a middle ear implant. So if this happens, this middle ear implant won't work. It's okay, it happens for one time, but if it is recurrently happening and if it's getting infected too much, so the mechanism or the electrical things that placed on this middle ear will also get affected. So what will we do? So that's the next question. So these are the main contraindications. That thing, if the patient have recurrent infections or the things happen though, so this middle ear implant is not an option. So then what we'll do, we'll go for a cochlear implant. Cochlear implant is like named as a savior of the people with congenital loss. They have like the kids who have profound hearing loss even in the beginning, like newborn kids with normal brain activity and neural activity. If they only have a problem with ear, that inner ear or mid ear, any ear. So for that kids in the back in a long time, they should go as a deaf. But now we have a cochlear implant. In cochlear implant, what we do is we directly stimulate what we know as the nerves. So what we do is we directly collect the sound from the environment, and our external processor will be there. It will like process the sound. It will send into the ear as a radio signals, and in the ear, where behind the ear, we will surgically implant a prosthesis and internal prosthesis. So which will receive the thing. There will be a transmitting coil, there is a receiving coil. So it will receive it, and it will like assess, and we can program it according to that. I'll come to that in the next thing. So we'll conduct the sound, process it, and there will be one electrode going into the directly into our cochlea, and there will be one electrode placed as a like earthing. So this cochlear electrode will go directly into the cochlea, and it will stimulate the nerves or basal ganglia, what we call, directly stimulate the nerve. So it is bypassing the outer ear and mid ear. So hence bypassing all the issues with this outer ear and mid ear. And the components, first thing is there will be an external processor which will be placed behind the ear mostly, and there will be a transmitting coil which is attached via a magnet, and there will be an internal processor and an internal coil to receive the signal, and there will be an electrode which is directly inserted into the cochlea to stimulate the nerves. So then what if the cochlea is also affected? So that's the question. For that we have another option which is still under research purpose. It's ABI, like brainstem implant, where we directly stimulate our brain or brainstem, bypassing this both cochlea and mid ear and outer ear. There are many things happens with cochlea, like there are many malformations. There are even the absent conditions in which the cochlea is absent. All these conditions, what we do is we directly stimulate the cochlea, directly stimulate the brainstem, in which there will be an external process which collects the sound, and there will be an internal thing like surgically placed implant which directly stimulate what we call as brainstem. Like from cochlea, these nerves conduct the sound to brainstem, which is a part of brain, and from this brainstem is what the neural part, or what we call as assessing and comprehension by brain. So this part is done by our brain. So we are directly stimulating the brain, but this ABI is under like research thing, and it's just coming up. So let's focus on cochlear implant, which is very like popular among now. So it's very popular among kids, like infants. So what with the infants? With infants, like there are a series of tests. So first we'll do a tympanometry, which will assess the outer ear. If the kid have any issues with the outer ear, and or if it have an issue, so we can't place what we call as a hearing aid, normal hearing aid. And then we will go for this tympanometry will also assess what is the condition of mid ear. If the mid ear also have an issue, or if it's clear also, it's okay. Then we will go for PTA or ABR. If PTA is the person have to respond, so if the kids will go for ABR. What in ABR, what we assess is our cochlea is responding from cochlea to the whole brainstem. We are assessing if the ABR giving like ABR is an electrophysiological test where we place electrodes over our head, and we are collecting this response directly from the brain. If the brain or brainstem or the whole nerves that they are like taking part in this hearing is working perfectly or not. This is what we assessing. In that, we just give the kids a signal, sound signal, and we place a series of electrodes over here, and you will collect the direct response from the brain. So then the hearing loss is like we divide into, there's mild hearing loss, moderate hearing loss, moderately severe, severe and profound hearing loss. For kids, we mostly give this cochlear implant for severe to profound hearing loss. So nowadays in recent researches, they are giving the doing the cochlear implant after 6 months itself. In India, we usually do it before 1 year, so that as we know, the sounds we hear from speakers will be a bit mechanical, or what we hear from this cochlear implant, which is not the direct sound, so it will be mechanical, like a robotic sound. So the kids should adapt it to it. So after the cochlear implant, there will be switching on, and there will be programming based on the kids' need. And what if the man is elder? For that part, we'll do because the man already know like how like he was already hearing something, so he already knows how the sound used to be, or how the sounds are. For that person, we still need a bit rehabilitation part, because he never heard such a like lived in such a exclusively mechanical sound world. So that too. And there's one more thing called Baha, in which we like, for the parents who are some or the kids with some complication in which currently the cochlear implant surgery is not required, or the person only have a moderate hearing loss. For that, we directly stimulate cochlea through our brain. So there are two ways in which we can hear. One directly through air, what we usually hear, but still you can see, like if we close your hair like both ears perfectly too, still we can hear. How? It's to the skull, like our bones of the skull vibrate or respond to the sound. They'll just vibrate, and these vibrations are directly like converted into, or directly stimulates the cochlea, because this cochlea, or our inner ear, what we call it, is still like sitting inside our skull. So this will cause the direct stimulation of cochlea. So through that way, we can directly place a implant on our skull, surgically implanted, or for kids they are like, we can just place it behind our ear, which will directly stimulate our cochlea through like the skin, and also through the skin it will conduct these vibrations to the skull, and the skull vibrates and the cochlea gets stimulated. So these are the four types of implantable hearing aids. That's mid-ear implant, bone anchored hearing aids or Baha, then there is cochlear implant, and auditory brainstem implant. And after the implant, what happens after the implant? So after the implant, we need rehabilitation. That is, as I said, if the kid is prelingual, or the kid got the implant before language acquisition, the kid need or the kid is profound, like have a profound hearing loss, or about 90% of hearing loss. The kid is experiencing the sound for the first time, so the kid need a guidance to like experience step by step how this sound works. So first we start with awareness. The kid should get awareness of, okay, if there is a presence of sound in the environment. That's the first step of rehabilitation, or what we call as auditory training or auditory verbal therapy. The first part is awareness, where we provide kid with awareness of sound. Okay, when we snap a finger or we make a sound, okay, there is a presence of sound in the environment. The kid should know that. That is the first part of rehabilitation. Then there is second part, in which the kid should identify. This is like, okay, this is the sound, this is sound, this is the identification part. And before that, we have to do localization. Localization is from which side the sound is coming from. Then the fourth part is comprehension, or different. We will do discrimination and comprehension. In discrimination, the kid have to differentiate. Okay, there's different sounds. This sound is different, and when we knock on the table, that sound is different. Like there's a different sound. He have to comprehend that. Then comes the comprehension part. There comes the part of language and speech and communication. The kid have to comprehend, okay, this sound is coming from this thing. or this sound is of my parents, this sound comes from fan, or this sound comes from some animal, like that. So that's the first step, that's comprehension part. So this is the normal rehabilitation goes for a prelingual kid. And what about postlingual man, who already heard some sound, but due to some accidents or some infections or something, their hearing got deteriorated. For this part, there's a postlingual rehabilitation in which this awareness localization will just do as a step because they already know how the sound is. Then we will work on comprehension, because every sound in the environment which we normally hear won't sound the same because it will be mechanical. So they want a postlingual rehabilitation. Now let me come to this is about cochlear implantation. Then why we do an ABI, auditory brainstem implant? In auditory brainstem implant, there are patients who have absence of nerve, that's our cochlear or auditory nerve, which will conduct the sound from ear to the brain. There are people with absence of this nerve, and there are people who have cancer like neurofibroma in the nerve. So the person will gradually lose the hearing after this tumor growing in our nervous system. So for these people, if we stimulate cochlea, this sound won't reach the brain, because the nerve or the wire that conducts that cochlea from cochlea to the brain is not there, is not present, or it's harmed. So we directly stimulate brainstem. Then what we have to tell about is how we assess or what are the candidacy to get into each implant. Okay, let me start with cochlear implant, which is more relevant for the kids. When they are born in hospitals, we will do an OA, which will just assess our cochlear hair cells or cochlea, in which we provide a sound and we will assess things and how the cochlea works. But about 70% or 50% of the kids will get positive, and the other will get absence of OA because of there will be fluids presence in the ear soon after the birth. So if the kid got a negative result, or the absence of OA, or there shows a problem with the OA, will go for OA after 2 weeks or a month. If still is showing that okay, the OA is still negative, or we still couldn't obtain a result, so then we will go for ABR, auditory brainstem response, in which we will stimulate our ear through a sound. If there is absence of ear, we can use skull vibration, that's bone conduction auditory brainstem response, in which we are stimulating the cochlea and brain, and in which we'll place some electrodes over the head and over the skin itself, so and head, and we'll collect the direct response from the brain, like how if the sound is directly collected from cochlea and to the brain. If it's okay, then it's fine. If the ABR is absent or is showing a profound hearing loss in both ears, we'll start assessing for an implant. For that, we have to go for an MRI. So we have to assess if there is any structural issues with that. Then we will have to go for ENT evaluation, like is there any medical issues, and surgical, surgeon's consultation, is there any complication with the surgery and all. And you have to do a normal blood checkup and all if he is okay or proficient for surgery. And they have to go get approval from all this one, and there will be an audiologist who will be assessing all these tests like APR, PTA, tympanometry, OAE and all. So this is the process that happens before a surgery. So in the surgery, what happens is we will place an implant directly over our mastoid bone, which is the bone that present just behind the ear. We will place the implant surgically inside, and we will place an electrode in the cochlea, which will stimulate the cochlea directly. So this is the test, this is the thing that happens in the cochlear implant. Then the next thing is how the speech develop in the kids. So as we know, these kids haven't heard the normal sound. First their speech will be delayed. so it's better to place the implant as soon as possible. Now it's done before 1 year of age, so the kid can be set into a rehabilitation part, which will include an auditory verbal therapist, a speech therapist, a clinical psychologist, like behavior therapist. Mainly these 3 parts will go day by day, and there will be part of surgeon, because after surgery they have to assess for surgical complications and all, and ENTC evaluation and periodic evaluation of hearing. So this is what happens, like the set of testing they have to go, or the set of things they have to go after surgery. So what with an auditory verbal therapist? Because he is not hearing the things, so they have to go for the steps I just recently said. All these steps, how like how the sound is there sound present, all these things, that their hearing part and the listening part, this will come under an auditory verbal therapy. After there comes a speech therapist, in which they have issues with like clarity issues will be there, because the sound we hear in the environment is that we speak. What we hear is we imitate that sound and we speak. So if there is a sound that comes from an external thing, it is a robotic voice which won't sound similar to what we hear from like surrounding normally we hear. So they have some clarity issues, and there will be a speech delay and language delay, because they are not getting all the language the normal kid used to do. So we have to give them proper speech therapy. Then the next part come with ENT and surgeon. They have to look for if there is any recurrent infections are there and all. And then the thing is an audiologist. An audiologist is who that programs that implant. So after 3 weeks of implant, after all these sutures are okay, or they are healed up, they will go for a switch on. In switch on, the first time the kid hears a sound, in this and it will be kept on for some days, and we will do the initial mapping, like if their all electrodes are working perfectly, or how much sound the person can, how much is the threshold of that electrode, and is he hearing well, and this all we assess in the first mapping. After 1 month, we will go for initial mapping, in which we will like if for the kids we will place somewhere between the threshold of electrode and a threshold of the kid at a level. Then we will go for a speech AVT therapist. In this AVT therapy, if the kid is lingual, or if the kid can speak, we will assess the needs of the kid. Like the speech therapist said, okay, this high frequency sound or these sounds the kids can't hear, or the kid is not responding well. That means we have to change the programming of the hearing, like the implant, like the need of the kid. And for a postlingual adult man too, if he is hearing, if he is saying that okay, I can't hear the sound that coming from a far away place or a near place, or he is hearing too much noise or too much disturbances, or he is hearing like a lot of unwanted sounds like that. So based on the needs, we will change the programming of the implant. And after the programming, like initially this is the first thing we do. Then after at least after 6 months, we have to reevaluate how they are hearing. For kids, we will go for a behavioral evaluation, in which a kid will be placed in a room, in a sound treated room, and we will like give different sound, and we will look out for the behavioral changes. If he is looking, if his eyes are squinting, like that of behavioral thing. If the kid is like after 2 years and all, we can directly test, we can give them a response button. If they hear some sound, they can respond like that. And if the kid is about 2 years, or if he is verbal, we can also go with a speech recognition test, in which we'll give them some words. The kid have to repeat the words. So through this test, we can ask which all sound the kids can hear, and which all the sounds the kid is getting, or the adult or the person or the implantee is getting difficulty in hearing. So based on that, we will change the programming of the implant. Like preferably for the kids, it's 6 months interval we have to do that. For the adults, if they are getting like issues, or they can't hear something, or they are feeling some clarity issues, we can change that. And as you can see, it's an implant. There are still contraindications, like they have issues of infections and all. This all happens, and this all happens with the implant. Like there will be infections over the skin. There like possibility of infections inside the ear. All this happens, but we can do the medical interventions for that. So it's better to like assess for 6 months interval, like how the implant is working and all. And the next thing, since our technology is improving, the implants are also improving. Now we have like 22 electrodes. Like the kid can hear almost like 99% of the whole sound that's present in the environment. And now there are direct phone connectivity, like we can connect our iPhones with or our mobile phones with the implant, so they can directly stream the music, they can directly stream the call and all directly to the implant, and it will give a better sounding and like reduction of noise and all. They can hear better and they can hear clearly from this streaming things. And we can, there are things, Bluetooth connectivity, and there's Wi-Fi connectivity and all, and there's mobile applications where we can control, like the not major controls, like minor controls, like switching off, switching on, for the especially for the kids, where they can like, and we can also apply a tracker on that, so that if for kids they may lose it, so the parents can track based the hearing aid presently at the location of the hearing aid, like that. These are the major interventions, like technological innovations that are coming up. And there are major, like in research purpose, there are still things like we can even change electrodes, and we can directly give medicines or like electrical changes into the cochlea. There are researches going on, and as I said, there's O-trip brainstem implant coming on slowly and slowly. They have some issues because we are directly implanting it to the brain, so it's still under thing. And because those who are implanted with auditory brainstem implant, they are still facing issues with frequency understanding, pitch variations and all. So these are still things happening. But for a kid who born with profound hearing loss in the past or before 100 years, they were like hopeless. They don't have anything like to hope on, like they don't have anything to like think on, because they have to live as a deaf person, isolated from the society. As we know, if we can't hear like music, if we can't hear others speak, all our communication part is going off. So for alleviating all this part, this cochlear implant and hearing amplification part, all this came up. First hearing aids came, then after sometimes there are kids who can't benefit from hearing aids. Then these implants came up, mid-ear implants, which is placed outside. So these mid-ear implants and bone anchored hearing aids came up. Then after this thing also, there are kids who can't hear things. So for these kids, cochlear implants came up. But as I said, there are still problems with hearing with cochlear implant. So then brainstem implant came up. So the important part is, there are two parts. One thing is corrective part. That's where this implants came up, and there's rehabilitation part. The rehabilitation part is very important, because even if we give proper implant or proper corrective thing, still if there is no rehabilitation, the kids won't get enough like advantage or enough things, or what to do with the implant, or what to do with the sounds that are coming from implant. That comes with what we give as a rehabilitation. So the rehabilitation is very important. So that's all. Thank you.
Pinnacle Blooms Network ప్రపంచ వ్యాప్తంగా స్పీచ్ డిలే, ఆటిజం స్పెక్ట్రమ్ డిజార్డర్, కాగ్నిటివ్ డెవలప్మెంటల్, సైకలాజికల్ రుగ్మతలతో బాధపడుతున్న దాదాపు 80 కోట్ల మంది పిల్లలు మరియు పెద్దల జీవిత ప్రమాణాలు మెరుగయ్యే విధంగా దశాబ్దాల రీసెర్చ్ తో కూడినటువంటి అత్యంత ప్రభావవంతమైన స్పీచ్ థెరపీ, ఆక్యుపేషనల్ థెరపీ, బిహేవియరల్ థెరపీ, సైకలాజికల్ కౌన్సిలింగ్, చైల్డ్ డెవలప్మెంట్ మరియు రీహాబిలిటేషన్ సర్వీసులు అందిస్తున్న ఏకైక స్పెషల్ ఎడ్యు హెల్త్ కేర్ సంస్థ పినాకిల్ బ్లూమ్స్ నెట్వర్క్. ప్రపంచంలోనే మొట్టమొదటిసారిగా పైగా మిరాకిల్ అనే పేటెంటెడ్ టెక్నాలజీ సహాయంతో అత్యంత పారదర్శక థెరపీ సర్వీసులను అందిస్తున్న ఏకైక సంస్థ పినాకిల్ బ్లూమ్స్ నెట్వర్క్. 100 మందికి పైగా నిష్ణాతులైన థెరపిస్టులతో మీ మరియు మీ పిల్లల బంగారు భవిష్యత్తు కొరకు పాటుపడుతున్న సంస్థ పినాకిల్ బ్లూమ్స్ నెట్వర్క్. భారత ప్రభుత్వ ప్రతిష్టాత్మక స్టార్టప్ ఇండియా అవార్డు పొందిన భారత్ హెల్త్ కేర్ ప్రైవేట్ లిమిటెడ్ యొక్క అనుబంధ సంస్థ.